All right,
Good morning.
recording is on.
Great. Welcome to this harm reduction training presented by Institute on Aging. This is a program of the IOA Clinical Collaborative Expansion of Services and is funded by the San Francisco Department of Aging and Adult Services. I'd like a few housekeeping details before introducing our speaker and her supervisor for today. I have put these in chat, but I'm going to, I think they bear repeating right now. Please, first of all, turn off your microphones and your videos, if you will. Thank you. If you don't, we'll find a way to turn them off for you, but it's better if you do it. Thank you. If you have a question for our speaker today, please write in the chat section. We're going to take some pauses throughout the talk to address these. When you see an owl pop up on the screen, that means it's a time for a question and answer session. We're providing American Sign Language interpretation today, and we want to thank Ann Smith and Shane Blau for being on board. They are our interpreters. This talk is being recorded and will later be available on Institute on Aging's YouTube channel, and I've put the link to that in the chat feature. When we get started, if you want a better view of the ASL interpreters, please put yourself in active camera view mode. And as I said, please mute yourselves and turn off your cameras. In fact, I would encourage everybody under the View tab, choose active cameras, and that's how you're going to get the best presentation today. In terms of continuing education, it takes about 10 working days to get the CEs. And if anyone has questions about this, please feel free to contact me, Catlin Morgan, Education Manager at cmorgan@ioaging.org. For those who qualify, which are the BRN, CAMFT, and MCLE certificates, those will be sent digitally along with fillable evaluations, which will be issued digitally. Now I'd like to turn this over to Ann Almendral, LCSW, Clinical Supervisor and Consultant, and lead Citywide Clinical Consultation Service of the Citywide Clinical Consultation Services. She will introduce today's speaker. Thank you, Ann.
Good morning, everybody, and once more, thanks for coming and joining us in this very important topic that all of us hopefully will gain a lot of experience and wisdom from. I have the pleasure of introducing Ashley Mooney, our clinical consultant for the Citywide Clinical Collaborative team. She is amazing in a lot of ways, not only in terms of the experience and education that she brings. She has an LCSW from
USC.
Yeah, USC. So I'll have her speak to more specifics about her education, but mostly having worked in San Francisco for quite a few years and having been in various positions of leadership and also hands-on in working with our community, brings together a presentation that is integrating harm reduction. And so without further ado, I'll just have her take over. And before that, I do want to say that this training is pretty amazing and big. So for those of you that have agencies that have more questions related to harm reduction and want to have it be more relevant to your client population, feel free to reach out to Ashley and I, all right? So we can do a smaller, more intensive training if that's something that would be beneficial for you and your agency. But ladies and gentlemen, Ashley Mooney.
Good morning, everybody. How are you? I'm Ashley Mooney. Thank you, Ann. Thank you to our ASL interpreters. We have Shane and Ann. And thank you, Catlin, for being my chat monitor voices. There is a lot of content to cover today, so I encourage you to put any questions or comments in the chat. We also have a number of breaks throughout the presentation, and I'll do my best to give you a heads up when we're getting close to one of those breaks so you know that we'll have an opportunity for discussion. And yeah, welcome everyone to the Harm Reduction Policy and Practice in San Francisco. This specific module is on behavioral health, and we're focusing on creating safety and reducing risk. Let's get started. So who is the Citywide Clinical Collaborative? The Clinical Collaborative is a joint case management project of the Department of Disability and Aging Services and the Institute on Aging that has provided clinical consultation and training services to community-based, DOS-funded case management and aging and disability resource centers across San Francisco since 2007. The team is comprised of licensed clinicians who provide individual and group consultations, skills development, multidisciplinary, and community trainings like the one you're in today, with the goals of supporting and promoting excellence in the provision of case management services to San Francisco's vulnerable, aging, and disabled adult clients. And so I'm the person on the left, and Anne is on the right. So here's the outline of the training that we're going to go through today. First, I'll go over the history and context of harm reduction in San Francisco. And then I'll define what I like to call behavioral health harm reduction. And then we'll put skills into practice by looking at a fictional case example. So consider the left side of this picture, the then being before harm reduction became a policy in San Francisco. So around the late 90s, and the now being now. This picture is one way of looking at how drug and alcohol use was approached from the standpoint of providers. Before harm reduction came around, use was looked at in binary terms, black and white, using or not using. And now we know there's much more than just the binary on and off, use or abstinence. And the many beautiful colors on the right side of this picture represent all the complexity associated with supporting those who deal with substance abuse and mental health. Harm reduction began as a strategy to reach people who weren't being reached by the usual medical or mental health system. And older models of labeling drug or alcohol users as addicts and demanding abstinence or leveraging housing or benefit opportunities in exchange for abstinence were not being effective long-term and weren't really doing enough to decrease HIV and Hep C infection, lower needle sharing, and help people avoid overdose, and help people avoid tragic and painful health consequences. And the community is also negatively impacted by people who are using or drinking or sharing needles and overdosing or engaging in behavior to maintain their habits. And they're also not always people that are able to make good decisions, which can result in assault, violence, crime, injuries in worst case scenarios. So instead of thinking about whether people are doing drugs or drinking or not, we're going to look at people's mental health symptoms, their drug use, their needs, and most importantly, their strengths to form a fuller picture of them as people. So here we have some foundational ideas of harm reduction. And a lot of these policies underline the main core concept of harm reduction. So compassion, non-judgmental thinking, and the self-medication theory, which is a theory that people use drugs and drink to medicate maybe symptoms or discomfort. Motivational interviewing, which is a counseling technique that highlights ambivalence. So feeling strongly in the direction of both change and not changing, and supporting people through the context of being not judgmental and helping people accomplish their goals. Housing first and healthcare as a human right is also an essential policy in understanding harm reduction. And many of these are based in the concept of the stages of change. So pre-contemplation, contemplation, preparation, action, maintenance, and relapse. So in this context, drug and alcohol use is contextualized not as a moral failing, but as a choice that has multifactorial considerations. The conversation and thinking around drug and alcohol use became less binary and more of a continuum. The issue was not whether or not people drank or used or why. It was how they did it and what else was going on when it was happening. And from this came a conversation about risk set and setting. The risk being the specific behavior. So that's drinking, that's using, that's any kind of behavior that puts your safety or other safety at risk. And set is the mindset that you bring. Are you hungry, angry, lonely, tired? And setting is all the person, places, and things around drug use, alcohol, or behavior. And so this widens a conversation from yes and no to who, what, where, when, and why. And so much more then can be done to reduce risk, and as such, reduce people's harm. And I'll just give a little reminder to mute. I am getting a little bit of background noise. Thank you. So with this greater conversation around set and setting, came thinking about how providers could better meet the needs of clients that are drinking and using. Ways to decrease overdose and limit dangerous withdrawal, like Narcan, and medications that decrease alcohol's hold on people, like naltrexone, become available. In 2003, San Francisco is the first city in the U.S. to make naloxone readily available to members of the public, drastically reducing the number of overdose deaths from injection. San Francisco City formally sanctioned syringe access in '93. And so needle exchanges become places where people can come and get clean needles, and injection kits become common. Even Walgreens and CVS have policies that people can exchange needles and buy clean syringes for minimal cost, and sharps containers become more common in housing and in the community. And the concept of safe injection and safe drinking sites becomes part of the conversation. In April 2017, the Safe Injection Services Task was formed in San Francisco. And places like the Sobering Center become places people can be brought to safely sleep and return to sobriety with the care and supervision of medical providers instead of on the street or in jail. Medications to assist people that are physiologically dependent on opiates like methadone, Suboxone, and buprenorphine become widely available. And finally, medical and social work providers are more open to having honest conversations about drug and alcohol use. And teams that go and meet people where they're at become kind of the hallmark of San Francisco's services. So that's community engagement, like ACT for assertive community treatment and ICM for intensive case management. So what is harm? I invite you to consider to expand the definition of harm. So harm is initially kind of defined as overdose, disease transmission, or physiological dependence. But what about people with mental health conditions? Substance use may be part of the picture. It may also not be. And harm comes in multiple forms. And for clients with mental health, that can be feeling more homicidal or suicidal, losing touch with reality, becoming more paranoid, being malnourished or dehydrated, or physically becoming unwell due to poor hygiene. And a client experiencing both challenges with mental health and substance use may feel more unsafe. And I think harm could be those things too. And so this slide covers maybe an increased definition of harm, and therefore an increased definition of what harm reduction might be. So it's not just overdose prevention and decreasing disease transmission and stabilization, though that's absolutely part of it, but also supporting people to not have to experience or experience less a lack of safety, being homeless or being incarcerated, and also being concerned about a loss of family and friends, loss of access, and loss of services. So harm reduction began with trying to prevent the most negative outcomes for people that use substances. And I argue the same approach can be applied to behavioral health, which is a combination of mental health and substance use behaviors and symptoms. And behavioral health harm reduction is the practice of learning about your client, identifying their risks, and setting them up for success. So let's define behavioral health harm reduction. It starts with a strengths-based assessment of your client's challenges and needs. understanding of the available resources and the skills to link the client with the right resources at the most appropriate time. It bears mentioning here that supporting individuals that are challenged with multiple complex needs, including substance use and psychiatric illness, is incredibly challenging. Therefore, any and all actions taken to decrease risk, honor autonomy, and improve our clients' quality of life are practicing behavioral health harm reduction. So we'll have a few friends kind of pop up throughout the presentation. I know that presentations can be kind of long, so I've got lots of pictures to hopefully break it up. And this owl is going to help us remember some things, and it's going to be kind of a pin to the major concepts of behavioral health harm reduction. So those are know your theories, know your client, and know your options. So we'll start with a discussion of the theories that are most relevant to behavioral health harm reduction. And these slides do get a little content heavy. Just want to put that out there for folks. So now providers are looking at drug and alcohol use more as a decision with risk that can be addressed by having open, honest conversations and offering options for support guided by the client's preferences and level of engagement. So clients that use substances are able to engage in the community and work on minimizing their impact their substance use has on them and minimizing the kind of most intense consequences. And with those most intense consequences kind of less likely, that makes room for managing other problems people have. And trauma is a huge contributor to substance use and lots of other challenges. And another is mental health. So a mental health diagnosis cannot be made until substance use is under control because the symptoms often overlap. And therefore, when clients engage with their providers to minimize their use or minimize the impact it has on their psychological functioning, it makes room to address other possible risks and harm, which is often an undertreated or untreated psychiatric condition. I'm going to zoom in on this slide because it gets a little tiny, but we'll see here. This is a description of PTSD risk factors because PTSD is often an underlying contributor to substance use, and substance use can often be an attempt to manage PTSD. And so a traumatic event can lead to PTSD if these other factors are involved. So previous trauma, neurological vulnerabilities, lack of support. Just going to remind people to mute, getting a horn or something. Genetics, life stressors, and existing mental health conditions. All right. We're going to give it just a second to see if that background noise goes away. Okay, good. So let's move on to looking at substance use. And substance use can be viewed on a spectrum. And understanding where a person is at on the spectrum is important for meeting people where they're at and finding appropriate care options that promote health and reduce risk. So I'll start at the left side of the screen with beneficial use, and I'll zoom in because I know it can be kind of tiny. So beneficial use is use that has positive health, social, or spiritual effects. So that could be using medication as prescribed or ceremonial tobacco. Then casual use that has negligible health or social effects. Then high-risk use that begins to have negative consequences for a person, friends, family, or society, such as combining multiple substances or driving under the influence. And finally, we have chronic dependence or substance use disorder, which is high risk that becomes habitual and compulsive despite negative effects. All right, and thank you for everyone who's reminding people to mute, and I appreciate everyone who's turned off your cameras and muted. I appreciate it. So here's another slide with lots and lots of words, and I won't go over them all here. You will all have the access to these slides after the training, as well as a specific resource list for behavioral health resources in San Francisco. But this slide I mostly have to cover the major ways people use drugs. And as a provider, it's really helpful to know these ways and be familiar with talking about them so that you can have an honest conversation with your client about the risk they're taking and see if they're interested in finding different ways to use that might cause them less harm and put them less at risk. So I'll zoom in. So the major ways people use drugs are smoking, snorting, and swallowing, followed by booty bumping or using a turkey baster, and injecting. And then this slide also goes over the risks and benefits to injecting drugs, but we won't go over that here. So this also goes over, this is the review of major diagnoses that we covered in our previous training. And I'll just go over the major symptoms that are involved with these kind of cluster of disorders. So in affective disorders, we see things like depression, mania, and hypomania, as well as anxiety. Thought disorders like schizophrenia and delusional disorder, where you see hallucinations, and those can be visual or tactile or auditory or hearing voices. And then also delusions are firmly held beliefs, despite evidence to the contrary, as well as thought disorders. You can see a lot of disorganization or people struggling to take care of their basic needs. Anxiety disorders like separation anxiety or social phobia, and we also see panic disorder and agoraphobia. And the personality disorders are kind of long-term ways of people being in the world. So these next two slides are fairly content heavy, and then we will have a break for review and discussion. I see there's a lot in the chat, so we'll make sure to get to as much as we can when we get to the break. Okay, so now we'll go into a conversation about comorbid behavioral health problems. And the left-hand side of the slide covers three different items: a two-hit hypothesis, trauma, and neurotransmitters. And the right-hand slide goes over what we call adverse childhood experiences. And I'll go into a little bit more detail about that now. So according to the National Institutes of Drug Abuse, comorbidity describes two or more disorders or illnesses occurring in the same person. And they can occur at the same time or one after the other. And comorbidity also implies interactions between the illnesses that can worsen the course of both. And about half of people who experience a mental illness will also experience a substance use disorder at some point in their lives, and vice versa. And mental illness can contribute to substance use, and substance use can contribute to the development of mental illness. The relationship between substance use and mental health conditions is complex, but there are a few main theories as to why they often happen together for many people. One is that there's a genetic component to developing both a substance use disorder and a mental health condition. This is the two-hit hypothesis: one hit for a genetic vulnerability and the next hit for environment. People's environment, natural supports, or resources have a lot to do with whether or not genetics or genetic vulnerabilities become activated. And trauma plays a significant role as well. So some people are genetically predisposed to be more sensitive to drugs or alcohol, or more at risk for developing a mental illness. But the environment they're in or raised in can contribute to that happening or not. And the table on the right covers adverse childhood experiences. And just going to remind people to mute. I'm getting a little background noise. So adverse childhood experiences are things that can contribute to mental health or substance use disorders if they happen more often in people's lives. And finally, neurotransmitters play a role in both mental illness and substance use, specifically in the regions of the brain that cover reward and decision-making, impulse control, and emotions. And the neurotransmitters are dopamine, serotonin, glutamate, GABA, and norepinephrine. And to talk specifically about the substance use disorder overlap with mental health conditions, substance use disorder is common among those challenged with anxiety disorders, specifically anxiety, panic, and PTSD. And other diagnoses that are highly associated with comorbid substance use and mental health include depression and bipolar disorder, ADHD, psychotic illness, and borderline personality disorder. And I'll zoom in on the right-hand side of the slide to give you more detail around the adverse childhood experiences. So those are on the abuse category: physical, emotional, and sexual abuse. Neglect is physical and emotional. And then household dysfunction can include mental health, incarcerated relative, mother treated violently, substance abuse, or divorce. So these are some of the reasons and theories behind how mental health and substance use can happen together. And the next slide we'll cover is talking specifically about these mental health and substance use in seniors. So this slide covers comorbid behavioral health problems in seniors. We'll talk a little bit about substance use in seniors, and then specifically SMI, or severe mental illness, in seniors. So seniors that use substances have specific issues. The 2018 National Institute of Drug Abuse study reported that almost 1 million Americans over age 65 have a substance use disorder. The life changes that happen in older age, so social isolation, physical illness, a decrease in functioning, or major role changes like retirement or loss of a spouse, put seniors at risk of both substance use and mental illness, and increase negative outcomes if the two occur at the same time. Substances can have negative impacts on aging bodies, exacerbate cognitive impairments, and cause accidents and falls. One study of 3,000 adults aged 57 to 85 showed common mixing of prescription medication, non-prescription drugs, and dietary supplements. And more than 80% of participants used at least one prescription medication daily, with nearly half using more than 5 medications or supplements, putting at least 1 in 25 people in this age group at risk for major drug interactions. Just another reminder to meet getting some background. Thank you. So seniors experiencing chronic pain further complicate this picture as they may be prescribed opiates for pain. The number of adults over 55 using heroin after being prescribed opiate medications more than doubled between 2013 and 2015. Marijuana use in seniors is increasing, and in 2017, it was reported by the CDC that roughly 8 out of 100 seniors over 65 smoke cigarettes. The most common drug for seniors to use is alcohol, with 65% of seniors over 65 drinking more than daily guidelines at least every week in the past year. And approximately 10% of seniors drinks 5 drinks in a sitting for men and 4 for women. Then I'll go into seniors. SMI is severe mental illness, which is mental health conditions that cause significant problems in functioning in some major aspect of life. So the needs of seniors with mental health conditions are complex. So people with severe mental illness tend to die earlier than the general population and are at higher risk for multiple adverse health outcomes. And they have substantially higher rates of disease like lung disease, heart disease, and other comorbidities. And a 2013 report yielded that over 7,000 adults over 65 died by suicide, which is roughly 17.9% of the senior population. So SAMHSA reports that 15% of adults over 65 experience some type of behavioral health problem, with 5% living with serious mental illness, including schizophrenia, bipolar, and major depression. And the aging of the baby boomer population is resulting in an unprecedented growth in the number of middle-aged and older adults with serious mental illness in the U.S. Okay, So I imagine there are lots of questions or something in the chat. So we'll take the next few minutes to answer any questions or review.
Hi, Ashley. This is Catlin. Can you hear me?
Hi, Catlin. Yeah.
As people are typing their questions in the chat, I have one for you rather immediately. Someone wants to know, can you speak to the increase of substance abuse since the pandemic began?
Just start out with a softball, won't we? So I want to speak as someone who's worked as a social worker by training, but I think also this audience probably holds just as much the answer to this question as I do. So I don't want to stand here in an expert position, but speak to what I imagine is likely contributing. So we know that isolation and being disconnected from people can drive people to substance use or exacerbate substance use because people are suffering, and being physically separated from all of the supports that people may normally have is happening on a scale we have never seen before. So people who might have, access to a daily hospitalization script or an adult day health center, a lot of those aren't open right now. And people aren't able to see family and friends and the normal kind of community support. And even, medical and psych providers are seeing people in a more distanced way. So the way people normally engage with care is different. The way people normally engage with family is different. The way people normally engage with friends is different. And so therefore, if you're removing all of these ways that people cope in a healthy way, now substance use becomes an option for people to cope. And so that's like a very self-medication theory of it. But I think that's a major contributor is people are isolated. People are not able to access the supports that they normally can. Yeah.
Right. Thank you. We have a question from Orlando Sanchez. He asks, do we have any recommendations if we want to apply harm reduction to hoarder clients, the people who hoard?
So that's a really specific question. I'd say we're going to cover more about assessment and safety planning further on in the presentation. And I'm hoping that there are some things that will be applicable to hoarding and collecting clients. That being said, if we don't cover it, Ann and I are more than welcome to branch off after this and look at how we can bring trainings like this specifically to populations. So if you don't get your answer covered, let's talk after the presentation.
Also, Ashley, of the 15% of seniors who experience a behavioral health problem, what is the most prevalent problem or the top few prevalent problems?
I have to go back and look in my statistics, but is the question like which behavioral health problem is common with which substance use problem?
Okay. You're asking me that, or?
I guess it seems like, so when I covered the statistic, the most, I think it seems like the prevalence is going to be your severe mental illness, right? Bipolar, depression, schizophrenia kind of thing. And then anxiety is also a major contributor, and PTSD. Those ones I think are the ones where people have a lot more impact. Their symptoms impact their ability to make decisions more than a less disabling mental health condition.
Thank you, Ashley. And then one last thing.
Yeah.
I see that Noel Martinez has mentioned Mhaosf support groups. Do you want to speak to that for people who might not know what that means?
I know what that is, but Manuel probably knows better than I do.
Well, we can speak to the Mental Health Association of San Francisco support groups, and it's a response to the question around applying harm reduction to hoarder clients. That's a really nice resource for people, clients who are struggling with hoarding and collecting, so that there are support groups that we can refer our clients to.
Yeah, no, thank you, Manuel. I see your quote, and that's absolutely true. Mental Health Association has specific like collecting supporters, so they'll send individual people out to work with people that have collecting behavior. But like I said, this group has probably a lot of really, really great answers to the questions that are coming up. So are we good on questions? Are we good to move forward, or are there more?
And do you have any others?
I think we're good. Yeah.
Okay, we can go on.
Okay.
Thanks.
All right.
Actually, there was a question that Karen had. Yeah, one of my clients has Down syndrome and was doing fine for a long time, and then all of a sudden, and when they became older, had a big behavioral change, you know, huge, you know, like 180 degree turn. They had big problems with socializing. People couldn't be around them. You know, before that they were fine, and then there was a big switch when they became older. And we're still trying to figure out what causes these kinds of big switches, you know, changes in behavior with older people.
Absolutely. Yeah. And thank you so much for sharing that, Karen. And I'm glad you brought up that example. Our clients are complicated, and things sometimes come out of nowhere. So, and there's many factors. So I'd say we're going to cover some of the kind of assessment techniques, but I think you bring up a really good case is that, you know, people can change very quickly, and it's hard to know what is driving it. But yeah, that could it be the development of a psychiatric issue? Could it be a substance use related thing? Could it be a behavioral issue secondary to some kind of medical problem? It's hard to know. And so I think what we'll cover now is talking about how to assess your client for what they need and try and connect them to the people that can make those decisions and get you the support that you need to support your client. Okay? All right. Well, thank you all for your questions. I appreciate it. So we'll get moving. So now that we've kind of talked about the context of harm reduction as it started in the city and the theories relevant to understanding it, we can kind of turn to applying those theories to our client. And as we turn to practicing harm reduction, it can be helpful to reflect that our role as providers and helpers is to offer dignity and respect and support to clients in their journey. And it bears mentioning here that often in the work of supporting those with behavioral health and substance use challenges, we witness trauma, both firsthand and vicariously. We witness suffering, we witness dysfunction, tragedy, and we witness decisions that we know can cause a bad outcome for our clients. But I'll offer this reflection in just a brief pause before we move on. So what I can do is offer myself, wholehearted and present, to walk with the people I love through the fear and the mess. That's all any of us can do. That's what we're here for. So now we've got our elephant back to let us know that we're moving on to the second part of the presentation, which is getting to know your client. And as we continue through this, please feel free to put any questions or comments in the chat, and we'll have another review with our OWL. So let's take a look at who our clients are in San Francisco. So who are our clients? This over here on a map is a map of our beautiful city. And this is specifically for the IDU or PWID population, which is the people who inject drugs. And this is from the San Francisco report that San Francisco City wrote on harm reduction. And this shows that the most concentrated amount of people who inject drugs is in the Tenderloin and in our South of Market neighborhood, with the rest more or less spread out across the city. And then I'll share a little bit of information about mental health conditions, and then go through San Francisco drugs of choice, and then share a poignant quote from the San Francisco Dope Project. So according to the National Association of Mental Illness, nearly 1 in 5 U.S. adults live with mental illness. So it's about 51.5 million in 2019. So roughly 20% of adults in America had a mental illness, more women than men, and the highest prevalence in the population of adults aged 18 to 25. And for severe mental illness, the prevalence in America is roughly 5%, again with more women than men, and the highest is among young adults aged 18 to 25. So the San Francisco major drugs of choice, 49.5% of our city uses heroin, followed by meth, and then a combination of other drugs. I'm sure the pandemic has probably changed a lot of these contours as drug supply has shifted due to the pandemic. You guys will all get these slides, and then these bottom two are links to the San Francisco Department of Aging and Adult Services infographics on our disabled population and our older adult population. And now I'd like to share a quote from the DOPE project, which is a San Francisco project working on overdose prevention and education. So in 2020, 699 San Franciscans died of accidental overdose, up from 441 in 2019. And just over 500 of those deaths involve fentanyl. So accidental overdose represents 43% of all medical examiner cases citywide. So the DOPE project says people experiencing homelessness and extreme poverty, Black and brown people, queer and trans people, immigrant communities, and people experiencing complex mental health issues and high rates of trauma continue to be disproportionately impacted by overdose and the catastrophic effects of the decades-long war on drugs. These communities also experience the largest set of health disparities, have been impacted disproportionately by the social isolation and economic desperation amplified by COVID-19, and continue to experience the highest rates of policing and incarceration. Though fentanyl, a strong synthetic opioid, is certainly a contributing factor to the city's steadily rising overdose deaths since 2018, it's not the sole reason, nor is it even the root cause of this crisis. Strong drugs just amplify the risk our communities are already experiencing. And in 2020, a global pandemic forced people into further isolation, chaos, and uncertainty. Our city's most vulnerable continue to suffer the most. And I have to say, I agree with the DOPE project's perspective. So now we'll move forward to a conversation about the specific skills of behavioral health harm reduction. So these skills are a combination of assessment and safety planning. So the skills of behavioral health harm reduction are first establishing an acceptable level of functioning or your baseline for your client's symptoms. So that could be a low, a medium, and a high symptom day. Same with substance use. And then next is establishing your client's supports that they need to remain stable. And then finally is creating plans for changes between baselines. So someone brought up a really good example of what happens when my client all of a sudden looks different, all of a sudden behaves differently. What do I do? These are some skills that might help with helping you figure out what the client needs. And so why is this process important? So knowing your client is an imperative step towards understanding their needs and setting them up for success. It also increases your individual skill set in connecting your client's symptoms, skills, needs, and making appropriate recommendations and referrals. The stronger your ability to assess your client's symptoms and identify what they're at risk for, the more confident you can be as a provider that you've properly supported them and created a plan for them to remain as stable as possible. Additionally, the more practice you have at connecting clients to resources that are appropriate for their current needs, the faster you'll be able to make assessments for new clients or anticipate problems for current ones. And furthermore, having a strong working knowledge of the resources available for your client, depending on how they're doing, really benefits them. Now we'll go over the fundamentals. So here's our elephant friend and reminding us kind of about some fundamentals we've seen before. So I'll go over them and then highlight a few other ones that are important when getting to know your client and completing kind of a risk assessment. So it starts with motivational interviewing, compassion and non-judgmental approach, which we have seen before. And then the ones I want to highlight are trust and transparency and leaning into discomfort. So a lot of the work in providing care to people that are struggling with behavioral health and substance use is getting to know them on their good days and their bad days, and being able to be honest with them about what you're seeing so that you can provide in a loving, supportive way them support to get to where they want to be. And so a lot of that will involve naming behavior and giving feedback and being honest and authentic. Sometimes our clients look really good, they smell really good, and they're taking really good care of themselves, but sometimes they're not. And it's hard, but sometimes our job is to give them that feedback and saying, like, I've seen you look better, I've seen you smell better, and I want to know what's going on so that I can help. Those are all important ways to build a relationship and help people reduce harm and empower them. So we're going to go over 3 major tools that I think are helpful in getting an assessment of your client and figuring out what they need. And so I'll cover a substance use baseline assessment, basic orientation assessment, and a mental status exam. I'm sure these are review for lots of you, but just a good kind of going over the tools that can be helpful in getting you all the information you need in making an assessment and seeing where your client fits. And so these tools help you create a baseline of your client's presentation and functioning. And baseline is a clinical term that really means their usual level of functioning or their usual level of symptoms. And so if you're in a case management role, these tools can be used at intake or during a formal assessment or reassessment, and as part of ongoing monitoring of your clients. And these tools are also vital to identify if your client's in crisis and should be an important part of every crisis intervention that you do. So tool 1 is going to be your substance use baseline assessment. So you're thinking about the continuum of substance use. You're thinking about the different ways people use drugs, and you're thinking about all the risk set and setting, as well as people's drug of choice, the amount or dose that they use, the route or method. We saw that in the past slide. Frequency, and also their withdrawal and overdose. So this is where building trust and being non-judgmental is really, really important, because it helps you understand what function substance use plays in your client's life and gives you a greater context around their risk. So this is tool 2, which is a basic assessment of orientation. This is from a mental status exam, and this is getting people's orientation to person, place, time, and situation. And while it's on its face really simple, it can reveal a lot about what the client might be experiencing. And it's important to ask these questions as often as you can, ideally every time you see your client. It may seem silly or like overkill, but subtle changes in the way they answer or their ability to answer these questions can give you insight into whether things are changing for them and whether or not they need extra care. So for asking people, seeing if they're oriented person, you might ask them to spell their first or last name. For place, you ask what city are we in, or what floor of the building are we on, what zip code, and time is, what time is it afternoon or morning, and situation, what is happening right now, or why are we talking? And all of these questions, if you know your client normally has a little bit of trouble answering what the situation is and all of a sudden can't tell you his name, something really, really big is going on and he might need more support. Okay, here is the last tool. And so this tool is the mental status examination. And this helps you get a really detailed picture of what your client is like. So first, you cover what your client's attitude is towards you. So is your client friendly? Are they engaged with you? Are they evasive or hostile? And does that change? That's another reason why doing these assessments frequently can help you see if something is changing from their kind of usual way of being. The client's appearance is important. What do they look like? What do they smell like? What does their grooming and hygiene normally look like? And do they look older than they should be or younger? Movement involves the way they physically hold their body. So if they're physically agitated, they might move around a lot. Or if they're really, really depressed, they might not move at all. Speech is the way people talk. So I'm a fast talker. I've been trying my best not to talk too fast during this presentation, but speech is a major indicator of how someone is doing. So if someone normally talks really slowly and you talk to them and they're talking really quickly, or if they don't normally slur their words and they can be an indicator that something's going on. Speech, you might also notice if the client is halting in their speech or speaking really quietly or really loudly. And the pandemic obviously changes a lot of how we do these assessments because we're having to do it over the phone. Affect and mood covers the emotional world of your client. Affect is the outward expression of people's emotional experience, which we normally look at as a range. So someone may have a broad range or a wide range of affect, which means you can see on their face and in their body if they're happy. If they're happy, they're smiling and laughing, and if they're really sad, they're crying. And the other end of that is a blunted or restricted range of affect. So someone may have literally no facial expression, or their facial expression won't match what they're saying. They could be talking about something extremely sad while laughing. And mood is, how are you feeling today? That's just kind of, are people feeling sad or angry or happy or excited? Thought process and content is whether or not people's thoughts go in an orderly or linear fashion. So if you ask someone, what did they buy at the grocery store, and they tell you items of food, that means that they're able to explain something in a way that makes sense. And then thought content is what they're talking about, bizarre or not bizarre. Because if your client normally talks about regular kind of things, and all of a sudden is talking about aliens or demons, that's a big shift. Insight and judgment is awareness of their condition, awareness of the challenges that they have. And judgment is the ability for them to make decisions on their own behalf and make good decisions for themselves. Memory and orientation. Orientation, we saw your basic orientation slide in tool 2. And then memory is short-term memory, long-term memory. So does your client remember what you talked about a week ago or a day ago? And changes in people's memory and orientation can be indicators of mental health issues or substance use or cognitive deficits, which we see a lot in the senior population. And then suicidal and homicidal ideation are an ever important part of a risk management profile. So ideation is the thought of harming yourself or harming other people. And so anytime you have a client that is talking about harming themselves or talking about harming other people, that's a really big red flag. And a red flag to ask further questions around intent, plan, and means. And then another important factor with suicidal and homicidal ideation is people's history. So not just the history of the person as far as attempting to harm themselves or harming other people, but also in their family. So if anyone else in their family has engaged in suicide or harming other people, it's just helpful to get a clearer picture so you have a better understanding of your client's risk. Intelligence is a factor to see if your client is kind of average intelligence or if they may be having a developmental issue that may make their intelligence lower, which may mean they have access to other resources. And then hallucinations and delusions. So we see these a lot in severe mental illness and then also in people who are acutely intoxicated or withdrawing. And hallucinations are hearing things that aren't there, seeing things that aren't there. Tactile means you can feel things that aren't there. And delusions are believing things that aren't true despite having evidence. So people can believe that others are stealing from them, or people can believe that other people are out to get them. And a final factor when looking at all these things is culture and language, because all of the way people hold themselves is through the lens of their individual culture and then also their language. So you want to make sure you are taking that into consideration when you're working with your client. So all of these tools are really meant to help you get an understanding of what your client looks like on kind of their regular, everyday, their baseline. And it's mostly so that you can assess when the client comes off baseline or is changing or experiencing a deterioration in their mental state. And so we describe a mental state deterioration as a change for the worse in a person's mental state compared with kind of the most recent information available. And it's important to use these tools often to be able to know what your client looks like on a regular day and then see if what you're seeing looks different. Okay, we have 2 more slides and then we'll have a break for review. So when we're looking at building kind of our understanding of our client, these questions help you identify your client's specific challenges or impairments that are unique to their mental health symptoms, their substance use, and their strengths. So you want to ask yourself, how do my client's symptoms or how does my client's substance use show up for them in their life? And what parts of their day or major tasks do they struggle with? And so we want to focus on the big ones, though we know that mental health and substance use can impact all aspects of people's life. The big ones really are food and water, clothing, shelter, and access to medication and care. And the graphics shows that mental health symptoms overlap with substance use, and substance use overlaps with daily activities, and daily activities overlap with mental health symptoms, which is to say that these all are related and these all overlap. And a lot of our work is figuring out, where does the client struggle most and how do we put services in place to help the client with their specific needs. Okay, so this is kind of putting all of this together. And this is a thorough assessment that ties all of your tools, linking of your client's symptoms and behaviors to their specific challenges and risks based on their unique issues, and the services that they require to remain safe, all within the context of strengths and supports that they already have. So now you've essentially created a justification of care based on the client's specific functional impairments, which is drawn from the client's unique symptoms, substance use, and risk behavior. So I'll read the slide. So first we covered symptoms and behavior, and you get that by using all three of the tools as often as you can. So the challenges and risks that your client has, you base that on their symptoms and their specific behavior. Through that, you can identify their needs or the services required or the referrals that are needed. And then their strengths. So what are some protective factors that guard them against risk? And so now we're ready to use this assessment to create a plan of action, to create safety and reduce risk, and complete the picture by identifying what level of care your client needs and how they can access it. And we'll take a break here for review before moving forward.
Yeah, thanks a lot, Ashley. So we do have a number of comments as well as questions. So I'll just start reading some of them now. A gentleman by the name of Paul Aguilar mentioned that he was part of the group that implemented Proposition 36 in San Francisco in 2000, initially through the San Francisco Department of Public Health, using the harm reduction model. And now he's noticing that there are no longer as many treatment modalities as available as was identified then. So I don't know if you can speak to that. Definitely are aware of that the need is greater than the resources that are available, and that we really need to count on our being able to be assessed, to assess our clients fully so that we can strongly advocate for alternative type of services. Can you speak to that some?
That was kind of a lot. What's kind of like the
the question is, well, it's not a question, it's more an observation this of not having as many treatment modalities as we need given the increased need.
Okay. So that much, I actually have some, normally I'm like, I got nothing for that, but I actually have something for that.
Thank you.
And the something that I have is we're going to cover that later. So what we're going to be going over is the specific options within San Francisco, and hopefully we'll go over something that identifies another option. But if not, I think,
okay.
Yeah.
Thank you. Thanks, Ashley. Second question has to do with, let's see here. Oh, can behavioral changes in older adults, this is from Frida Lopez Ruiz, like substance abuse, who have no history of substance abuse, can be attributed to possible health declines like cognitive impairment?
Absolutely. Yeah.
We definitely have seen that. And I might just say that this is changing a little bit in terms of when the cognitive decline is more noticeable. I think it used to be just referred to as middle age, but we all know that with the baby boomers defining what middle age is now, we're noticing that the cognitive decline is more common among people who are 70 and above rather than the 50 and above. I think that the nutrition, activity, employment, and socialization has definitely accounted for a pushing up of the age where we actually noticing cognitive decline. And then what was the other thing? Just in terms of, I think, Ashley, you did talk about that people who have severe mental illness tend to have shorter lifespan. And so I might want to reiterate that. And then finally, I just wanted to say about when we're noticing with our clients the mild cognitive decline, usually the first thing is confusion and disorientation, where routine tasks such as paying bills, shopping, meal preparation become more and more challenging.
And I'll add, I guess, as far as cognitive issues or behavioral changes, I think this is why it's so important to have like a care team, and as like a case manager or social worker, you're kind of like the air traffic control of coordinating all these people, because a behavioral change, it can be just substance use, and it can be just mental health, and it can be just medical, but more often than not, it's those 3 or 4 things all interacting with each other. And so it's important to also make sure that when you're working with a client, that you're in touch with, as much as your client's able to engage with providers, like a primary care and a psychiatrist, if they have one, and neuropsych, or a neurological assessment, and also making sure people are up to date on their kind of medical conditions, because things like UTIs can cause massive behavioral changes for people, and you wouldn't think that those two were related, but they can be. So I think it's hard to tease out.
Yeah.
And Karen Lee, I believe, had a comment as well.
Okay, go ahead, Karen.
Yeah. So yeah, my the point about culture and language. What I've seen from my experience as being a deaf person, that many deaf clients have a lack of communication access with, for example, if there's a change in a client's mental health condition and they're referred to a social worker, or a psychologist, we have to say, remember to provide a certified deaf interpreter for the session, and, to really match the client's needs. Plus, an ASL interpreter, if they just get any ASL interpreter, sometimes it's really hard, hearing ASL interpreter might not see all the nuances of the language, and it's much better to have a certified deaf interpreter. So, and a lot of people don't know what that means. So, we do have a lot of explaining to do, but it does, it gets difficult. And care providers, it would be nice if they had more knowledge about the needs of deaf culture and the language. I know that UCSF, they had some services there with deaf clients who had mental health issues. And we see more and more mental health issues because of a lack of communication. And related to the culture as well, also, Chinese culture. I am deaf and Asian. My parents are Asian. But I've been working with my team who are all deaf. And, we do see a lot of behavioral changes, again, on our team. And we have to work with the languages that, our clients have. So, we have to sometimes translate things into Chinese. But there are these conflicts that come up, and it's hard to handle all these situations with culture and language, taking all those considerations, keeping all of them in mind.
Absolutely. Yeah. Thank you so much for sharing.
Yeah, thank you so much for that. It's a great reminder that there's so many layers of our being able to be sensitive and humble as we are in this field. So, but yeah, if you want to continue to speak to that, Ashley, I think that would be great. But there are a couple of other comments that people have. Okay.
Yeah, I think culture and language play a role in mental health and substance use that can't be overstated. And even just how people communicate, right? Someone, like, one culture may think that hearing voices is like a medical condition that you need to medicate, and others view it as, a divine experience. And so you know, culture influences the way we do everything. And I think part of the way, you know, providers are often trained is to practice cultural humility and asking people how their culture influences them versus, you know, making an assumption. But I think you bring up a really good point in that the deaf community has unique needs, and every population with unique needs, you know, then can be isolated and feel left out if there isn't if there isn't work done to try and include them. And it can really make people feel more isolated and struggle more if they're not feeling like they can reach out because providers won't understand them.
Yeah, thank you. I think on a slightly different note, and somebody had mentioned that more people died of drug overdose in San Francisco in 2020 than of COVID-19.
I mean, isolation and, you know, not being able to go the places we normally go, or people have lost jobs, you know, the grief, I think that's kind of in our psyche kind of can't be overstated.
Yeah.
All right, well.
Oh, I had one more question, if that's okay.
Yeah.
Karen?
Yeah. Actually,
how do psychologists or psychiatrists determine if someone has, you know, a mental health issue or what medication to give? Because there are so many cultural and language issues there that overlap. You know, how do they determine the issue, the true issue, and the kind of medication or what have you?
So I can't speak to what a psychiatrist does because I'm a social worker and it's outside of my scope. But what I can talk about is I'll talk briefly about how diagnosis works. And diagnosis is not a perfect science. Diagnoses are based on what the provider observes and then also what the client reports. And a combination of those two things while also taking into consideration, hopefully, language and culture. But diagnoses normally are made based on, you know, a pretty limited amount of time. So it's, you know, the last 6 months, the last year of specific symptoms, and people kind of fit into a box. So yeah, that's how diagnoses are made, and then diagnoses also change, right? People can update a diagnosis if clients are experiencing something different, or if their behavior is changing, even if they're not talking about it. Does that kind of sound right, Anne?
Yeah, I might add. I might add that the critical aspect of diagnosis is to try to figure out what treatment to provide the client. And in the optimal instance of holistic treatment, it's actually made not just by a psychiatrist or a physician, but in concert with a multidisciplinary team. And in the inpatient world, the multidisciplinary team includes psychiatric social workers, psychiatrists, psychiatric nurses who are very well versed in observing behavior, and mental health specialists. And as supporting Ashley's position that this is a very inexact activity, but sort of a way to determine whether it's predominantly thought disorder, then certain sets of medications to address the neurotransmitters will be given, or is it more of an affective disorder, in which case another set of antidepressant type of medications will be given. I think it's science in the sense that we're seeing more and more neurobehavioral changes as a result of the medications that are being developed. But I think there's another aspect of healing in the psychiatric world that is, for lack of a better word, spiritual and social and community-wide. I think it goes back to the comment from Murray, getting to know the person is crucial. Role for early intervention and the introduction of a role model gently guiding and validating positive behaviors.
Great, awesome.
We want to make sure that we support the idea that it's not like we say there's a lab test that say you have schizophrenia, because there isn't. there are only observable behaviors that we can glean from and decide, okay, this set of medications perhaps will work. What I've seen in the inpatient world is it's a combination of team making the determination of what the primary diagnosis is, which also could include drug and alcohol issues, or even opiates or prescription medication abuses. But at the end of it is a multidisciplinary team as well. Okay.
Great.
Answers
Well,
your
thank
question.
you thank you so much for the question and for the conversation. This was exactly what we were hoping for, was bringing information out and then seeing kind of what comes back. So I really appreciate you guys sharing. And so we'll move on to kind of the last part, which is knowing kind of what your options are in San Francisco for reducing harm for people. So we've got our elephant guy, he's back, and he's saying that we're kind of towards the home stretch of knowing what your options are for reducing harm for San Franciscans. But obviously this goes towards everybody, but it's specific to San Francisco resources. Okay, this is another slide we have seen before, and this is just to remind us that we are expanding the definition of harm to include not just trying to prevent people from overdosing or getting a disease, but if we look at mental health in context with that, also helping people stay psychiatrically stable. Because if people are psychiatrically unstable, they may behave in ways that aren't truly them because they're unwell. And that might cause them to decrease in functioning, might cause them to use substances and be at risk of intoxication or withdrawal. Might also cause them things like a lack of safety or losing their house, losing their home, or being incarcerated. And I think a really poignant one is folks that are psychiatrically unstable and don't have the supports that they need can lose family, lose relationships, and lose access to care and lose services. I know there's lots of providers in this room, and so I know that there's definitely been moments where we have to deny people care because they are so unwell. And so I want to expand harm to be, okay, that can also be harm, and how do we work on getting people the care that they need so that they maintain that access and that stability. All right, so this is a big detailed slide. I'm not going to go over all of it, but I did want to draw you guys' attention to the San Francisco ecosystem of care. And this is part of San Francisco's whole person care model. This is only part of the entire San Francisco ecosystem of care, but it does go over the urgent and emergent services in our city, and then transition and stabilization services, as well as recovery and wellness. Now, this is from the Department of Public Health specifically. So this is not an exhaustive list of everything available to people in San Francisco, but just a place to start. So I will focus first on the left side in the mental health and substance use. So I will go over the urgent and emergent care for mental health first. So PES is Psychiatric Emergency Services. That's inside of General Hospital. And that's kind of the main place to go if you are experiencing a psychiatric crisis. So if you're feeling suicidal or homicidal or gravely disabled. And PES is also the entryway to the inpatient part of the hospital, the inpatient psych part of the hospital. And that essentially means you get brought to PES, or you go on your own. You can self-report, and that can initiate a 5150. And a 5150 is what is a 72-hour hold. Can be less, but can be no more than 72 hours, which can then result in a 5250, which is kind of the longer hospitalization. From there, we have things like conservatorship go on. But falling down on our list, you have acute diversion. And acute diversion are 2-week crisis residential treatment programs. They're specifically run in San Francisco by Progress Foundation. And those are programs set up to divert people from psych emergency. And we'll go into, and yes, Nikki, I can do gravely disabled in a second. But acute diversion is meant to work with people who are in psychiatric crisis that don't need to be in a hospital environment, which frees up the hospital and PES for working with the people that really need that level of care. And I'll go over what that level of care looks like a little later. And then mobile and Westside Crisis are crisis clinics that mobile crisis will go to you, and Westside Crisis is a walk-in. And Door Urgent Care is a 24-hour urgent care clinic that people can, self-present to from the street, and it's in south of Market. And there was a question about grave disability. So grave disability is kind of the third way that you can get to psychiatric hospitalization. And it's a more gray area credential, and it means that you are unable to meet your own basic needs for food, clothing, and shelter because of your mental health condition. And so that's a little tricky to identify in the community, but generally it involves, not being able to make decisions around how you're going to get food or how you're going to get appropriately clothed or where you're going to sleep. So someone who is gravely disabled, you may find them in a park with, lice or something, and they haven't eaten, and you ask them what their plan is for food and they can't answer. That could be a gravely disabled person. And then as far as urgent substance use in San Francisco, Sobering Center I mentioned before, and then medical and social detox are detox environments for people coming off various types of drugs, tends to be opiates, and then social detox is a residential treatment environment as well. And then I'll move into the middle part, which is going over our kind of transition and stabilization services in San Francisco. And you can get to all of these through the Access team, which is the San Francisco Placement Team, Behavioral Health Access Center, and the Treatment Access Program. All of these specific, the Access part, will be in the Behavioral Health Resource List that you'll get after this training. And so as far as mental health transition and stabilization, we have residential treatment and intensive case management, as well as Hummingbird Psychiatric Respite. And that is a drop-in psychiatric facility. So it's not locked. It's just like a regular kind of treatment building that people can go in from 10 a.m. to 6 p.m. They have access to overnight beds and jail psych. And as far as transition and stabilization for substance use, residential treatment is pretty much the way to go for substance use. And then to close out for kind of recovery and ongoing care for mental health, we have outpatient, which would be your outpatient therapist, your outpatient psychiatrist, your outpatient case manager. And case management, there's different levels of care of case management. So you've got regular level is, monthly contact, intensive case management is going to be more than that. And board and care is kind of the long-term support for people struggling with mental health conditions. And a board and care is a place that people live and they have supervision kind of during the day, food and medication taken care of for them. And outpatient for substance use is going to be outpatient and peer. So that's a lot of meetings, 12 steps, smart recovery, life ring, methadone maintenance, and buprenorphine. Okay, so those are kind of your main options. So let's talk about making a safety plan. So a safety plan is going to be, you're covering these kind of 4 bases. First is identifying the major risk and asking yourself, which one of the many problems my client has is the most dangerous and the most likely? And then you want to protect against the worst outcome. So what can I do to avoid the worst case scenario and enhance stability? So what can I do to shore up the supports and that help keep my client stable? And connect them with relevant resources. So how do I connect my client with what they need? Someone is not muted and there are bells. So I'll remind everybody to mute. Thank you. Okay. So first part of making a safety plan is taking care of the basics. And Want to just shout out to IOA here. The Clinical Collaborative is part of IOA, and IOA covers lots and lots of things and touches lots of people's lives, and wanted to just show all the services that IOA has, and then we'll go over a couple other San Francisco services. So IOA has home delivered meals, intensive and non-intensive case management. We also have the Friendship Line, which is a 24-hour mental health line for seniors and isolated people with disabilities. We also have support at home, kind of like an IHSS, and community living fund to help people get access to things that help them stay at home instead of be in the hospital. We have centers for excellence for people to drop in and have social day programs, as well as medical on site. And then we have dementia care and suicide prevention and elder abuse prevention. So if you are looking for any of these services, you can go to ioaging.org. It's a good way to take care of the basics for your client and get them kind of like a multiple services all in one go. And I'll just remind people to mute. I am getting some background static, please. Thank you. Oh, still hearing some background. That's okay. Okay. So more taking care of the basics, and this is also really San Francisco focused. I'm hoping a lot of these resources are refreshers for folks, but you want to, for folks who are dealing with mental health and substance use, you have to kind of put some things in place to make sure that you don't have to worry about them starving, or their wounds not being cared for, or their diaper not being changed. Because if those things aren't in place, then the rest is going to be really, really hard to accomplish. So Project Open Hand and Meals on Wheels provide food for people, and nutrition is kind of the mainstay of stability, mental health, substance use, all of it, and especially in seniors and for folks that are taking medication. And then care, we have the Public Authority, IHSS, and Homebridge provide care in people's home, and it's a lot of how people are able to stay home instead of be institutionalized. And then Alto, Scriptside, and Daniels are pharmacies that provide delivery, and I know Kaiser also delivers. So these are all the basics you want to kind of make sure you've got in place before moving on to thinking about other levels of care. Okay, so here are some things to consider when looking at the levels of care for substance use and mental health for your client. So kind of looking at the ecosystem of care slide, you know, whether they're in the red for urgency or yellow for kind of transition. One is ability to contract for safety. If your client may be experiencing suicidal or homicidal ideation, but if they can tell you, no, I'm not going to kill myself today, then they have access to care that is not the hospital. Intoxication and withdrawal level, so their ability to withdraw safely in the community. If you're not a medical provider and you're not sure if your client is safe, I would send them to a medical detox or the hospital just to be sure, but it's something to consider. And then your client's need for containment. So regardless if it's substance use or mental health, you want to know if your client actually needs someone to put their hands on them to be safe. They cannot have their needs met in a community program. It's going to need to be in a hospital environment. And then your client's interest in an engagement with both structured programming and community supports make a big difference as to where you might try and aim them as far as places to get care. And like with residential treatment, not every client wants to pay program fees and do chores and live with a roommate and sit in groups or go on outings or go shopping. So it's something to think about when you're offering those options to your client. And then also is access to medication support or detox. Okay, I'm seeing some action in the chat, and so if there are questions, which I imagine there are, we will make sure to cover those in the in the break. So this is level of care consideration specifically for a psychiatric risk. And so if we look at like a low risk thing, that would be someone who has an ideation, so plan to hurt themselves or thought to hurt themselves, but with no plan or intent. And then medium would be ideation with plan but no intent or behavior. And then a high risk, so someone who would probably need to be 5150 would be someone who has made a potentially lethal suicide attempt or homicide attempt, or has persistent thoughts of it with strong intent or rehearsal. And you will get these slides, so if you didn't get all of what I just said, you'll have these slides to look at later. So when discussing options for care, you want to make sure the options are guided by the client and really grounded in dignity and respect for your client. And you want to offer as much acceptance and compassion as you can. And then widening your conversation to cover what is meaningful to them. What do they like to spend their time doing? What do they find meaningful? So I put some nice pictures here of our beautiful San Francisco, but then also someone reading, someone maybe meditating or engaging in something spiritual, or just chilling with some popcorn and TV and Netflix. And then you want to look at your client's social supports and then their spirituality. So we'll have one more slide and then we'll have a review. So the warning signs for behavioral health are, regardless of the cause, you should be concerned about a loss of reality testing, thoughts of suicide, thoughts of homicide, and refusing food, water, or care. All right, we'll have a little review and then we will move on to our case example.
Hi, I'm going to be funneling some questions to Anne Almendral to ask of Ashley and co-answer.
Okay, thank you so much, Catlin. Yeah, I was scribbling as fast as I can to try to catch as many of the questions, Ashley. So, and some of them are comments, some are questions. The first one has to do from Michelle Grace Liasanda, wanting to address the resources and tips on working with codependent couples, and what might some ideas related to codependency.
Well, just start with an easy one, huh? I mean, codependency is tricky. So codependency is like when there's just not a lot of boundaries, and one part of the couple may. Are you talking about substance use? Well, either way, boundaries.
I think that was it seemed like that was the intent of the question, addressing the codependent couples, older adults who are at different states of acceptance in their substance abuse, with one having an active disorder. So basically, it's all of the above.
Yeah, I mean, a lot of that. Yeah, so then it's identifying. You know, that's a lot of practice of you know, from the provider's point, of identifying where they're at as far as stages of change with the individuals, but then also with the couple, and then working with them around, like, okay, you guys as a team, like, what stage of change maybe are you at working together towards these goals? And so then it would be identifying whether or not they can be, whether or not their services are together or separate. Right, so I've seen couples go through treatment together. I've also seen couples be separated because maybe each of them aren't at the same stage. Right, one client might be in contemplation around use and is actively using, and the other one is wanting to try something else. And so identifying whether or not you've got capacity to manage both of them, or if they need to be separated. And then if you're going to work with both of them together, identify kind of what intervention is going to meet both of their needs, given that they're at different levels, and supporting their maybe communication between the two of them.
Yeah, and I think you know, the full assessment of both parties, and then the relationship, and then from there figuring out what would be the best treatment interventions and supports that can be available for both of them, and also the relationship. There's another question, and maybe more comment about the pandemic related to cognitive functioning. I guess every day is Blur's Day.
Yeah, I agree.
So just be aware that we are, the other question has to do with, for Murray, differential diagnosis related to severe mental illness and delirium. And yeah, we can try to take a stab at that.
Yeah, I think, differential, diagnosis, like delirium versus mental illness, I mean, they look similar, right? Someone experiencing an acute psychotic episode may be disoriented to person, place, and time, just like someone experiencing delirium. So then I think it's doing your frequent assessment and then making sure there aren't other causes of delirium, like a medication or substances can obviously be part of it, but making sure you've got access to do a full kind of medical or psych or neuropsych assessment to be able to tease out the two. Because delirium can have like medical causes and also psychiatric causes. And then I think there's also like a time factor, right? So delirium may exist in a different kind of timeline than severe mental illness, and severe mental illness may have impairments that are separate from delirium. Does that kind of, Anne, do you want to
that covers it. I think the issue of the eye to the onset and the precipitous drop in function. Those are just the things that I might add. Another final question has to do with, from Orlando, saying, unfortunately, most of our clients refuse mental health services, and this is to some degree cultural. How far can we go applying harm reduction so that they may agree, for instance, to take medications, allow people in so they might start cleaning their homes, and to start using medications for their mental health condition?
Yeah, great question. I'd say a lot of it is identifying what the client wants. Like, we're clear on what they don't want, right? They don't want mental health. They don't want people in their house. But it's identifying what their barriers are, right? Like, I think sometimes clients have had really negative interactions with the mental health system, or they don't understand exactly what engaging in mental health services looks like, right? Like, I'm a practicing therapist myself, and like, maybe people don't know that you would just come and sit and talk to me, versus, they're thinking it's like a hospital environment. So having honest conversations about what prevents people, and you as a provider can give that information about, like, okay, what exactly do you not like about the idea of therapy? And how can you address some of those barriers, maybe put some of those anxieties at ease for your client? Or how can you offer more control to the client? So if they're concerned about people coming into their house, would they feel better about the idea if they say, were able to pick someone who shared their culture, or they were able to pick someone who shared their language, or if they got to be involved in the process of interviewing? I know there's lots of semantics around getting all of that done, but identifying, like, if your client is saying no, like accepting the no and hearing the no, but also saying, what if, right? What would need to be different for this answer to be different? And identifying where your client is at with the stages of change around it. Because there are probably some days where they do want to deal with mental health, or where they do want to talk about medication, but maybe just not all the time. And so our role is to open the door to have a conversation about the day when they wanted to talk about mental health.
Yeah, that sounds great. And then the final question has to do with...
Actually, I think we have 2 more questions.
Two more, okay, sorry. Yeah, so we have, okay, here we go. Aaron is asking, what if the client's unaware? Oh, I actually responded somewhat to that question. The question is, what if the client is unaware or does not understand the reasons for their behavior, mood swings due to bipolar disorder, or delusions and hallucinations due to schizophrenia, even for your best to explain what is going on? And I think, Ashley, you've addressed that. I also responded to Aaron about how we do try our best there. I think for me, the determinant factor for what level of intervention I use, and this is something that has been reiterated over now by Ashley, is safety. If you're feeling that the symptoms are whether they're of a bipolar disorder, of a schizophrenia, thought disorder, you will have to decide what level of intervention to bring in. For example, the San Francisco Mobile Crisis Team to do an evaluation, or a 911 non-emergency police call to evaluate for 5150. Because at the bottom of it is, are they danger to self, danger to others, or gravely disabled? In which case, that is the level of intervention. If you don't see those red flags for harm to others and self and grave disability, then you might go back to the points that Ashley was making around meeting them where they are, using the language that is familiar to them. Additionally, using examples of if you are diagnosed with having diabetes type 2, you agree to take medications because it has proven to improve diabetes and the symptoms. What's the difference with tells you that taking this medication in addition to talking with me will make you feel better? So let's see.
We have a question from Julio.
Yeah, Julio. Hi, Julio. Okay. Yeah, so and this is something that we definitely want to share, open it up for people for ideas as well, because Ashley and I have been addressing this with a number of circumstances that we've seen. During the pandemic and shelter in place, clients reported their needs by phone only. How do we address clients' risks when there's no observations during our initial assessments that we're able to make? You want to?
Yeah. Yeah. I mean,
there's people. We basically open it up because it's a very thoughtful questions, and I think people have discovered ways of trying to
do
make.
we want to maybe go through this the practice example and then have like a larger conversation at the end, or cover it now?
Good question. Yeah, actually, I think we can fold that question into the case example that you have. Let's try that.
Okay, guys, because I'm looking at the time. Looks like we have 13 minutes. I personally can go past 12 o'clock, but I know that everyone is busy. So
yes.
I want to make sure we get to all the content, and then we'll just kind of let it ride after that. All right, so let's put some skills in practice. Okay, so we're gonna just talk about Jerry. This is not a real person. So Jerry is a 62-year-old Caucasian heterosexual male living alone in a permanent supportive housing building in the Tenderloin. Jerry carries a diagnosis of schizophrenia from his psychiatrist. Jerry also has diabetes and likes to use alcohol and crack. Jerry usually has a belief that everyone outside of his Meals on Wheels delivery person and his homebridge provider are aliens that are out to get him. He uses about 2 pints of vodka and $10 of crack. Jerry is on SSI and has a third-party payee that pays his rent, with the balance coming to him around each month. So each day, a client may have different challenges, and that kind of depends on the day. Hence why getting to know your client is so important. So once you've kind of completed your assessment, you can identify what your client needs depending on the day they're having. And so on some days, your client may not need very much. On others, they may need watchful waiting and a backup plan. And on other days, there needs to be immediate intervention to keep them safe. So we've got Jerry here. This is kind of his overall kind of experience. And then we'll go through him on a good day, a not so good day, and a really bad day, just to kind of talk through what each day looks like and what options we might consider. And the options are not exhaustive. There are always more than just the ones that I have here. Okay, so let me tell you about Jerry on a good day. So Jerry is CAO ×4, which means he's oriented to person, place, time, and situation. He's friendly and well-groomed, bathes every day, moves normally, talks loudly but clearly and at a normal rate. He's a restricted range of affect, and his affect is appropriate. Euthymic mood means kind of neither here nor there. Linear thought process with only minimally bizarre thought content. So he mentions the aliens and their evil plans in passing. He has insight into his illness and exercises enough judgment to drink his usual amount and eat food and use crack at his normal amount. He has some memory challenges, no suicidal or homicidal ideation, or CAH, which is command auditory hallucinations, although he does have a history of those. His intelligence is normal, and he denies hearing voices or seeing things that aren't there. So he tells you he's seen the aliens in his apartment before. Jerry gets his medication and food delivered. He accepts his caregiving and reminders about bathing, and his symptoms are under control. He's honest with you about using substances and can tell you where he's at and how he's managing it. So he eats in between drinks, smokes instead of shoots crack. Yay, Jerry. So we've got our safety plan kind of in your bottom right. So identifying the major risks, protecting against the worst outcomes, enhancing stability, and connecting with relevant resources. So on a good day for Jerry, things are pretty much kind of as usual, and he's got what he needs. And then if things start to go badly, which he's got a number of risk factors here, resources to consider would be our IOA Friendship Line, the Mental Health Association Warm Line, and Hummingbird Psychiatric Respite. Okay, so this is Jerry on an okay day. So on a more symptomatic day, Jerry is CAO times 3 and struggles to tell you why you're on the phone. Jerry is guarded, more rigid and slow in his movements. He talks more quietly and slowly. His affect is darker and more restricted. Dysphoric, irritable mood, some loose associations and bizarre thought content, and is minimal in his conversations about his substance use, but complains about running low on money and hurting himself on a broken bottle. Memory is worse, and he reports hearing the aliens are talking about him and their plans, which is making him irritated and preventing him from sleeping. He's suspicious of his caregiver and delivery providers, saying they look more like aliens than they usually do. So here we can see there's a bunch of things that are kind of starting to become more worrisome. So for Jerry, we might consider the urgent care clinics or the psych stuff about the aliens, Hummingbird Psychiatric Respite, maybe mobile crisis, maybe the sobering center, depending on what kind of is going bad most quickly. And then this is Jerry on a bad day. So Jerry CAO times 1 and can only tell you his name. He's evasive and hostile, disheveled and smelly, rigid and erratic, whispering and intense. Labile affect means he's all over the place. Dysphoric, angry mood. His thought content is illogical and bizarre. He has no insight and poor judgment, expressing homicidal ideations with intent and plan to take his best knife to the next alien he sees outside of his home. He says the alien voices are getting too loud and he needs to stop them. He's unable to entertain other options and has refused his caregiving and medication delivery for 2 days. So this is a situation where we need to call 911 because Jerry's endorsing homicidal ideation with intent, plan, and means. He also has additional risk factors of having diabetes and not taking his medication and hasn't received his care. So he's definitely 5150 criteria for homicidal ideation, but could also be teetering towards grave disability or could need to be in the hospital because of diabetes. Okay, so this is the overall, putting it all together with Jerry. And in the interest of time, I'm just going to say we want to cover his symptoms of behavior, his challenges and risks, his needs, and his strengths. And I'm going to scoot us over to the next slide, which is his safety plan. You guys will all get these slides after. Okay. So for Jerry, we want to identify the major risks for him. So his risks are poor self-care and hygiene, diabetes, alcohol and crack use is definitely dangerous, and paranoia, specifically around persecutory delusions. So we want to identify, depending on the day, which of these risks is going to be most likely for him and most dangerous. We want to protect against the worst outcomes. That's going to be, for him, malnutrition, diabetes, decompensation due to his schizophrenia, and then substance use, overdose, or withdrawal. And we want to enhance his stability. And the ways we can do that are working on a good home bridge care plan with his providers, and making sure Meals on Wheels stays present, collaborating with the on-site social work and property management, and working in the friendship line. And then connecting for relevant resources as they come up. So that's the urgent care clinic, Hummingbird Psychiatric Respite, mobile crisis, the sobering center. If Jerry's wanting to go to Joe Healy Detox, he can do that. You also could consider APS and then looping in his medical and psych team, as well as his money manager. So this would be an overall safety plan for Jerry. And then to wrap up, we'll look forwards. So this training is one of a few that we're going to do on harm reduction. So this one was specifically around behavioral health, mental health, and substance use. But as you can see, this really dense slide is the larger San Francisco ecosystem of care. And it covers medical, mental health, substance use, housing, and social. And so this was module 1. And in our future modules, we'll be looking at how we can use harm reduction policies to support clients in all aspects of their life. And this is also in keeping with the whole person care concept. And in closing, I wanted to offer you all a beautiful picture and say, I'm a lighthouse rather than a lifeboat. I do not rescue, but instead help others find their way to shore.
Thank you, Ashley. And we're going to be turning it back over to Anne to pose some questions.
Yeah. There are, let's see, I think we've addressed a good number of them. If you can, let's see.
Karen Lee has a question. She will need to open up her video. There it is. And Anne Smith can interpret for
yes.
Thank you.
So just to be fully transparent here, I do some volunteer work. I drop off food at various different places for homeless folks.
Wow.
During COVID, I have seen a lot of issues while I've been doing the food drops. You know, I'm doing the best I can to do socially distanced services. But when I see people, you know, if folks come up to me and they approach me for the food, I'll check in with them. I'll kind of talk to them about where they're from, if they have a place to stay. And one person told me he used to work, he used to have a job and he'd become homeless. So we walked back and forth. We talked back and forth for a little while writing. It seemed like he had a history of PTSD. He was a vet, and so we talked about where he would go to get services and treatment. And he said that he had run out of services, that he would not get any more services. And when I tried to ask why, you know, why wasn't he getting state services? Why wasn't he getting federal services? You know, if he has mental health issues, why was there any sort of timeline, or why did he lose services at any point? So do you have any insight into why someone's services would be taken away?
Yeah, I do. So it depends on lots of factors. So depending on where you're attempting to access services, I'm not a VA social worker and I don't have a ton of knowledge about the VA, but I know that the VA has options for people in the community. But just as I said in the beginning, if people's behavior is really kind of off the charts, you can be denied services if it's like a walk-in clinic. I know that insurance can also play a role. So like people can use an acute diversion clinic to stay for 2 weeks without kind of running out their access to care. But other levels of care, as far as residential treatment for psych, there is kind of a time at which point, like Medi-Cal and Medicare will no longer reimburse. So that can be a barrier for people. But normally that's really kind of at the end of the line. So I'd say insurance could be a factor, but then also like where is he trying to access care? Because like city mental health things, like if you just walk in to PES, if you're in emergency, it doesn't matter what your insurance is, they will care for you. So I would just be interested to know what he has attempted, and how we could maybe direct him towards the places that don't have the barriers he's encountered, like psychiatric respite or PES or the urgent care clinic.
Okay, thanks, Ashley. There is, again, in the interest of time, we have a minute. So thank you, everybody, for being here. I appreciate your engagement and the questions and comments. One last thing that I want to address is the request from Carmen Lee that she wanted a blank copy of the behavioral health harm reduction form so she may be able to use it. I think that's a great request. We also wanted to remind you that this is a lot of topic areas to cover, and if you're interested in delving a little bit more to address questions related to your specific clients, then reach out to Ashley and I. Our information is on the closing discussion. Also, a reminder that it'll take 10 working days to get the continuing education units from our education manager, Catland. So make sure that you complete the evaluation as required. And if you have any questions, please direct them to Catland. And she is cmorgan@ioaging.org. And then what else? In terms of signing up for the future modules that we're doing, we tried to partner very closely with our overall IOA education program. So we try to catch the Eventbrite invitation that gets sent out. So that's how you might be able to sign up for meetings such as this. And what else? We could also put, now that you've attended, we can definitely put you on education outreach list. And it comes out, the Eventbrite invites come out once a month. So hopefully you'll be able to access those. And let's see, and then finally, thank you so much for a wonderful presentation, Ashley. I think definitely thought-provoking and a continuation of a discussion around making sure that our clients are getting the best quality care that they deserve. So thank you, everybody.
Thank you all for coming.
Yeah, awesome.
Thank you.
Bye.
Bye.
Yeah.
Thank you. Bye.
Bye-bye. Thanks. So let's stay on.
Thank you. Bye-bye.
Bye-bye.
Thank you. Have a good day.
Thank you so much for joining us.
Okay,
Bye.
have a good weekend.
You too. Bye.
Bye, guys. Bye, Silvio. Thanks for the comment.